My name is Arelis Martir. I'm a geneticist, so a genetic doctor diagnose and treat genetic conditions. My specialty is cancer genetics, and I did a fellowship in cancer genetics specific at City of Hope, and I see at City of Hope many patients who have been diagnosed with breast cancer, some that have family history, very strong family history. The genetics world has changed a lot recently. In 20 some years ago, we learned about BRCA1 and BRCA2, and we have learned we have a lot of information, new percentage. So if we want to talk what is really new, there have been not a lot of changes in recommendations, but there have been changes in the numbers we give to the patients. We used to say everybody has a 50% chance of having a second cancer after a first cancer, but now that they have been studied with lab registry, we say more in 27% in the next 20 years for somebody with a BRCA2 and 40% in the next 20 years for somebody who has a BRCA1 mutation. Like I said, there have been no big changes in recommendations. The huge change in genetics. Everybody can hear me?
Okay. Turning the radio down.
Okay. The main change in genetics has been the new genes that we have been testing for. Some of the genes we knew a long time ago that they were associated with cancer, but we were not able to test because of the patent that BRCA1 and BRCA2 gene had. But the good news is after that patent went down, the genetic testing is broader, it's more accessible now, and I lived through all these years. I know how expensive it was, and the test is now very affordable. So the test cost should not be a deterrent for genetic testing anymore, even when some insurers may say you don't meet clear criteria. There are many genes. We have ATM, PALB2, CHEK2, they're associated with breast cancer mainly. CHEK2 is associated with colon cancer, ATM with a potential risk for ovarian cancer, possible pancreatic cancer. There is also other genes that we know are associated with ovarian cancer that in the last ASCO meeting they mentioned breast cancer is likely to be PAR, BRIT1, RAD51C, RAD51D. So these are other genes that we are learning. And there are newer genes that are not in guidelines, like MBN, BART1, that we know are associated with breast cancer, but when the patient has a mutation, what is their risk? We don't know yet. So what we're looking forward is in the next few years, when there is more data about the percentage. For example, for some of the genes that I mentioned, that we know there is association with breast cancer, when the patient comes with a cancer and they're making surgical decisions, there is no recommendations or enough evidence to recommend prophylactic mastectomy. And it's a discussion with the surgeon and the patient. And in many cases, the patient decides to have a balear mastectomy because of the screening. So the screening will be the same, mammogram, 6-month MRI for all these genes that we're still learning about. And many patients, because of anxiety, the idea of going every 6 months and get checked and waiting to see what happened, especially when they have already gone through a diagnosis, is very difficult. And the uptake of balear mastectomy is high in these patients. There is also new recommendations from the it's a statement from the American Society of Breast Surgeons, and this was very recent. They're recommending everybody who has breast cancer to have genetic testing. We have guidance from the National Comprehensive Cancer Network that said younger than 45, or 2 family members, 1 younger than 50, or ovarian cancer, or 3 family members. They're saying that everybody should have genetic testing, and in my experience, I agree with that because we see many incidental findings. We see many patients who doesn't meet criteria, who we found mutation. Another new recommendation from the American College of Medical Genetics is there have been changes in their statement. The previous statement was in 2000. 2012, I believe, and they're saying that for physicians to understand that when they send a patient for genetic testing, it's likely that the geneticist will recommend a larger panel, not only for breast cancer. And again, because the test is, because it's affordable, and because what we have seen, I'm a big proponent of large panels. So the larger the panel, as long as the patient get the pre-test and explain what is, if I have a positive, what would be your recommendation? What if I have an inconclusive? As long as they understand, I think that patients want to know as much as possible, the majority. For those who they don't want to know, what I said is make sure that call us in 3 to 5 years to see. Well, I say that to everybody because it has changed so fast, and we keep learning. It's important also that at least in the Miami Cancer Institute, and I know Dr. Carcas, we work together. We share genetic counselors, and we also give recommendations for patients based on family history. And in some cases, if they carry one of these mutations that we don't have clear recommendations, looking at the family is a good idea to get the patient in the screening that they will have if we have clear guidelines. So the patients usually go with a lot of information. There have been, and I can present many cases of patients without any family history of a certain cancer that we found mutations. And I think that BRCA1 and BRCA2 opened the door for this field of cancer genetics, and we're learning about other cancer risks that these patients have, because it's possible to have more than one mutation. That is a possibility. For the